hi everyone. I am Mary Beth Popniewski. I am the programming director here at SCAN. I'm just looking at our attendees and I see a few names that are familiar to me and some that are new. So SCAN is a nonprofit located at the Monmouth Mall. We've been serving the senior population in Monmouth and Ocean County for the last 34 years. So I hope that if you want to learn more about us, you'll visit our website at www.scanmj.org. And I'm just going to ask that everybody mutes their microphones and I'll mute it for you. We're so happy to have Dr. Goldberg with us once again. Dr. Goldberg is Palliative Care and Hospice Director at VNA Health Group and Monmouth Medical Center. But I always feel it's best to have our presenter tell us more about what they do. So Dr. Goldberg, I'll turn it over to you.
Thanks, everybody. Welcome. I think I'm quite terrible with names, better with faces. So if you're, but I do recognize some people that were at the first session. So we're so happy to have you back again for the second session. I started out, for those who weren't here last time, so I started out my career as a geriatrician and worked as a geriatrician for a number of years. I was always certified in palliative care and hospice, but only made the transition to do that full time about 7 years ago. I was doing it just part-time for patients. The principles are very much the same, and really love to teach. And so I really love the opportunity to share with all of the members of SCAN in previous brain health fairs and other opportunities to speak with you about lots of topics about aging, health in a good way, and what you do about it. So last time we talked a lot about the difference between palliative care and hospice and kind of when you might be thinking about hospice. And some questions did come up. Actually, it was a great segue to our second session today. A lot of questions came up about hospital and paying and, you know, when the hospital kicks you out and those kinds of things. And so the session tonight is that we're going to talk about how does insurance pay for these things and some more details about the logistics of it. So I apologize, it's a little bit more dry than some of the videos that we saw last time, but I think it's a really important topic because usually this is the most perplexing thing for patients and their families. And it actually causes more stress than you would think, that making the decision about hospice may be more of the stressful situation. But I would say in my experience, figuring out how to take care of someone on hospice or with a chronic illness becomes one of the major stressors that I see with patients and their families. So being educated ahead of time will help you prepare for that, to be able to decrease that stress in a very difficult time in general.
Okay, you want me to share slides?
Okay, so we'll start with the slides. As last time, if you have any, pretty open. It's a smaller group this time, right? How many? I don't know how many people we are.
We still have some more coming in along the way. So
okay, so but always, if you have a specific question, you could write it in the chat box, and we should certainly have a lot of time to answer your questions. So jot them down, and then we could go from there. Okay. Okay, so I start with this slide because this is the chaos of what we deal with every day for someone who has a chronic illness, because we have this back and forth between the hospital, rehab, home care, back to the hospital. And sometimes that gets very frustrating. Now, if you remember what we talked about last time in terms of hospice, is that so for palliative care, meeting someone who can help you identify your goals of care and help take care of your symptoms in any of these environments is really going to be important to you. When you talk about the idea of hospice in these environments, really the question we're asking is, do you still want to be in this chaos, in this back and forth to facilities, hospice, home, hospital, home? And if you're at a point where this scenario is no longer really what you want to start thinking about, how do I get out of it? I'll be honest with you, this chaos is true for not only patients like that maybe yourself, your loved ones, but the doctors too. It's really there's a lot of stressors on our end to avoid you keep coming back to the hospital because hospitals get some stress if they have a readmission after a short period of time of being out of the hospital. So just know that the stress is not only for you, the stress is also for all your physicians and the support team that might be taking care of you at home or in the hospital. So it's a two-way street, I think, and we're all looking for solutions to help avoid that stress. Okay, so this is when we talk about payment. I don't know if you all know this. I would say probably all of you are on Medicare. I would assume majority of you are on Medicare or thinking about being on Medicare. So Medicare are for the older generation. When you will actually be eligible for Medicare depends on how long you've been paying into the system. Generally, it's thought to be around 65, but that number does change depending on your situation. There's different parts of Medicare just to go reviews because that'll help us in thinking about who pays for what moving forward. So part A is when I use the medical shortened version, so I apologize. I should have just wrote. So part A is an inpatient. When you're at the hospital, part A pays for your bills to be at the hospital. Part B is when you go to the doctor's office, outpatient. Any equipment you might need, DME is durable medical equipment, and any outpatient therapy that you're going to, physical therapy otherwise. Part C is a specialized Medicare program called Medigap. It's kind of, many of you might have a secondary insurance to take that gap of payment, AARP, other private insurances that you might be buying to take the burden off for payments from Medicare. And Part D is your prescription plan, which you don't necessarily have to choose, but many of you probably do, where you have a prescription plan that you choose. Now, there's many of them, and essentially the way you decide is basically what the majority of your medications are. Each of these programs have their own formulary. And so you kind of the best way to do it is to look to see the majority of your medications and see the cost involved in each of them. Unfortunately, formularies change on you. So there may be a time where you get frustrated because your medication that you've been taking for 20 years has always been covered, and then they change their mind and they change the formulary and now you need to switch. Generally within the same class of drugs, but may not be the exact medication. But those are the different parts of Medicare that are going to be relevant for you. Now, the more important thing, which becomes a stressor, is that Medicare, even if you pay your premiums, does not pay for everything 100%. They only pay 80% of the time for all of these items. So that's why many people get that secondary insurance, that Medigap, wherever you have, you pay the premiums for those things, but they pay that 20% that Medicare doesn't pay, so you don't have to pay out of pocket. And that's why you are probably recommended to have something of the because otherwise you'll get a bill for whatever is going on for that 20%. Now, what's important in this also is when I talk about Part A about inpatient, that means you have to be designated as inpatient status at the hospital. This is a whole new trend, which I know gets frustrated for a lot of people who are hospitalized, is that they tell you you're in observation, right? Has anyone been in that situation where they hear that they're in observation? And observation is not necessarily that I'm just being observed. I know you wish it was just that. Or I had a little ER visit, they watched me for a little bit and they sent me home. It could be feeling exactly like you went to any other hospitalization you've been in, where you went upstairs, you got a room, you were getting medications from the doctors, but the insurance has designated that while you are there at the hospital is only meant for outpatient. Meaning you didn't really need to be at the hospital. That's something that you could have done as an outpatient. And so they bill it at a level of Part B, which means you get a copay, right? So it's a very high copay because you're in the hospital and you're getting hospital level billing. I could tell you that I experienced this, not with me personally, but with my daughter. So when she was 6 years old, she fell and she broke her elbow. She had surgery with anesthesia and but those surgical procedures were considered outpatient, even though she was in the hospital and you couldn't do the surgery anywhere else. I
Wow.
was like flabbergasted. Okay, she's 10, turning 11 now. So it was just in this start of where observation status kind of came into play, is because the insurance companies are trying to, be smarter about how they're spending. And so they're finding ways to save some money. But it's important for you to know, because you might get something, they may come to you, and if you're in the hospital, God forbid, and they tell you, oh, you've been designated to be in an observation status that has other ramifications down the line. It's rarely something you can fight, to be honest. It is very, very regimented by the insurance company, and the hospital is very careful about designating inpatient versus observation, because if they bill you as inpatient and the insurance later on says that you're observation, they have to give that money back. So it is a big deal for them, because they have other downstream issues also. So just be aware that's a concept for it. Okay, you could next slide. Okay, so remember that craziness of all those places? So I just want to talk to you about all these terms, so that way when you are in the situation and choosing, you really understand what this all means. Okay, so once you're in the hospital and then they want to send you home, there's lots of different options about where they might give you some advice about where to go or what to do. So let's just review them quickly so you understand them. Acute rehab. Here, I don't know where you live, but like JFK and Edison is a big acute rehab. Gosh, what's it called now?
Encompass Health. Yeah,
That's what it's called now, right?
yeah.
So JFK and Edison, Encompass in Toms River.
Tin Falls.
Tin Falls. There's two, right? Toms
Yes.
River and Tin Falls. Okay, so those are acute rehab. So what does that mean? Is that there's two designations to get to be eligible for acute rehab. One is that you probably have to have a certain diagnosis. So a lot of people go there, God forbid, if they've had a stroke and then a new stroke, or they've had some kind of injury to their brain, or they have a medical thing that they need, a real medical, like an acute heart attack, right? Where they now need more aggressive things. If they have a hip fracture of both legs, or they went for bilateral hip replacement as an elective procedure. So there has to be some sense of a diagnosis that needs, from its nature, needs aggressive physical therapy. But to be eligible for this, you also have to be able to participate in about 3 hours of therapy a day. And it's a combination. It's a combination of physical therapy, occupational therapy, speech therapy. It kind of looks like school. I remember when I first went to visit an acute rehab, you got a schedule every day, and it's very regimented. You have this, then this, and then you have lunch, and then you have this, and then this, and your OT, PT, speech, lunch, snack, dinner. That's kind of what it feels like. But you have to be able to physically you won't never be perfect, but you at least have to be able to participate in 3 hours of therapy. And for some people, that's, even with some of those diagnoses, that may be just too much, right? That ideally you'd want to get some kind of therapy like that, but it's just too much for them to undertake after, depending on the illness. So then you're talking about what's called subacute rehabs. And those are probably more commonly used. They're all usually housed in a long-term care facility, like a nursing home, where they generally have their own floor with their own gym, and they do physical therapy. Now, the difference between acute rehab and subacute rehab is the amount of hours you're required. There's no indication for diagnosis, okay? So you don't have that diagnosis thing like you have in acute rehab. You also have to do a lot less therapy. You only have to be able to participate in 1 hour of therapy compared to 3. So that's a lot, right? But then you also sit all day, the rest of the day. So it isn't as stimulating as acute rehab, but it is for some people who need that extra therapy, but really can't go home or don't want to go home yet and want to have some more daily therapy, but can't really do for 3 hours. Next is long-term acute care, LTAC. So what that is, it's kind of like a step down from the hospital. Majority of these patients were in the intensive care environment. Maybe they have some respiratory issues that they need more help with. And so they're moving over to not a hospital, but a step down unit. And majority of the time, those are related to respiratory breathing stuff, where they need to have some more aggressive medical care for it. but they're not ready to leave the hospital back home, and they need a little bit more support. So that's the only closest one is actually in Lakewood, right on the campus of Monmouth South. That's really the closest LTAC to our area, your area geographically. And that they have to approve you. Not all insurances approve, although Medicare usually does, if you have a traditional Medicare. Oh, I didn't talk about that. Traditional versus HMO, that's very complicated, but I'll talk about that. Let me talk about that briefly. So the difference between traditional Medicare and an HMO, which you generally have to choose, is that they provide a lot more coverage for things that Medicare traditionally doesn't cover, like hearing aids or other things, but they are very limited in the scope of doctors that are participating in the program, and you can only go to their doctors. So your premiums might be lower, you might have more coverage for that time, but you also have limited number of doctors who will take that insurance, who are participating, and so you may lose some of your doctors that you've had for a long time by switching to that kind of program. But there's a risk and benefit in that, and that's for you to individually choose. Okay, so we talked now skilled nursing facility. Skilled nursing facility are for, do you live there? Sometimes they do some maintenance physical therapy, but you're not getting even the hour a day like you're getting at subacute rehab. So these are for patients who can't go home, who need 24-hour support for their personal needs, but are not even able to participate in a subacute rehab. We'll talk about who pays for that in a little bit. Home care. Home care is if you go home and you don't want to go to a subacute rehab, and you want to go home and be home and do some physical therapy at home. So that's a post-hospitalization time period. Usually Medicare pays for that. It's usually only a few weeks. You have to have a medical skill that you need a nurse to come out to check on you, and you get some physical therapy, but you're really only getting therapy a few times a week compared to every day at a subacute rehab. So you see, as you change levels, you get different amounts of therapy. You probably have to really push yourself to go to something like a subacute rehab, not to go to a subacute rehab and to go home and do therapy, because you're going to have to do stuff in between those sessions with a physical therapist, or you're really not going to make a lot of strides in terms of improvement. And then there's our patient therapies. So you go to a facility, right? And you go, I don't know what's near you guys, but you go to you get a prescription from your doctor. You go to the therapy place once a week or so, however, what the program is. Generally, insurance covers a certain number of block of weeks at a time. And the therapist has to submit if you're making strides or not, or if you need more time. That's, again, covered under Medicare Part B, because it's an outpatient program. Acute rehab, subacute rehab, long-term care are generally covered as part of the admission on Part A, right, from the in-hospital Part A section of Medicare. Now, the only thing is they don't pay indefinitely. So Medicare post a hospitalization pays completely for 20 days. Day 21 until day 100, there's a copay, just that 20%, just like you have. So again, if you have a secondary insurance, that secondary insurance will pay for that 20%, the copay that the rehab place will charge you. Now, if you don't have that ability to cover it, they're going to ask you to leave or bill you, and you have to choose, can I pay it out of pocket if you don't have that secondary insurance? There's a max in a calendar year of 100 days of rehab. So even if you're in the hospital 4 times and each time you go to rehab for a little bit, at some point you may not have any rehab days left for that calendar year. So it's something to think about, right? If you have a medical illness where you're in the hospital a lot and you've been to rehab, you may have to think about an alternative option, or maybe even though it's a convenience to go to rehab, you may choose not to kind of save some of your days for a future need if you're closer to that limit. So just keep that in mind. Any questions about that? That's a lot of information on one slide. Okay, so we'll go to the next one. Okay, so we talked about so the question is who pays for what? So who pays for palliative care, right? So palliative care, you should see as any other specialist that you go for a visit. So if I see you in the hospital or I see you outpatient, I bill for my physician services just like any other specialist that you would go to. In the hospital, I bill as a consult just like any other specialist, your GI doctor, your cardiologist, your rheumatologist, whoever is coming to see you, you bill for a physician visit just like anything else. Now, some Pal Care providers do have an outpatient kind of environment. I know for me, when I was down at Monmouth, I had an outpatient clinic that I saw a few patients at. At Jersey City now, I only see in the hospital for right now. Eventually that might change. And VNA, we have a palliative care program that we go out into the community to your own home and visit you there. And there are doctors and nurse practitioners throughout the state that will come to you, go to nursing home facilities, go to your private home, and they do the same thing. They just bill as a doctor visit, just like anything else. Okay, so let's talk about the history of hospice a little bit, and then we'll talk about how we pay for some of the services under hospice and what they are. So in 1988, the medical group as physicians began. Okay, so we're talking about a very young specialty, very, very young, clearly, right? And they established an Academy of Hospice, like a medical support group as kind of a membership. And it changed its name in 1993 to the Academy of Hospice and Palliative Care Medicine. Now, I know I look like I'm 12, but I was alive then, right? So I was in high school when it just changed its name and kind of came to fruition. So that's really young, right? I was already thinking that I was going to be a doctor, and some of the doctors didn't even have this specialty to even consider, right? But how do we pay for this support, right? So in the Congress, in the Equity and Fiscal Responsibility Act of 1982, created hospice as a Medicare benefit. So Medicare is generally seen as the light where other insurances compare themselves to, okay? And then in 1993, so only in 1993, did it become a required federally mandated benefit in every kind of insurance, not only Medicare, but in retail insurance and private insurance otherwise. So it didn't designate exactly what all those benefits are going to be. They're vary slightly, but only in 1993 did it become a federally mandated benefit for everyone in the country, right? So think about that, right? We're not that far off from there. Mm-hmm. And so when we talk about some misunderstandings in the last time, and we'll talk next time too, misunderstanding of what hospice is, realize this is why. There are generations of doctors who never even had the word hospice in their framework. And so when they've taken care of patients, they didn't even think about it, right? So they thought about, it wasn't even part of their language and their training. So thankfully today, just people like myself who teach a lot of medical students and residents and the next generation of learners and nursing and community and people like you, right? So there are people who never even heard these terms, but now they're being trained to understand it and to hopefully incorporate them into their clinical plan. Okay, next slide. So it sounds really great, right? This is a benefit that is part of your Medicare benefit. Unfortunately, though, only 20% of all those enrolled in hospice, only 20% enroll in hospice during their last 6 months of life. This is all Medicare numbers, right? Even though they're Medicare, right? So you're older, you're more likely to be closer to the time you die than some other patients, right? Other people. Only about a quarter of Medicare costs are spent in the last year of life. So we're spending a lot of money in the country on people who are going to pass away in a short time anyway, but they're not utilizing this hospice benefit. That would still come from Medicare and be their right, but they're not utilizing it. And that's why we're doing a lot of education like we're doing tonight, so you understand what your benefit and when you might use it. There's also a little bit of bias, right, of when you would consider something like hospice, which I hope if you were at the last visit, you kind of heard that it's not really the only thing you use it, you would consider it for. But hospice care, it's more kind of accepted that people are going to be on hospice if they're going to pass away from cancer, right? It's something that is more acceptable in bias and that euphemism, all that stuff we talked about last time, that it's really being used a lot more for patients who have a cancer diagnosis. And only 20% of overall all patients on Medicare are actually using hospice at all. And so that's really a shame, because hospice can provide a lot of benefit to you and your family members during a very difficult time, when we already kind of see that you're going to pass away soon. Even if the time is short, it would be really a benefit to all of you to have a good quality of life during that time and utilize the resources that are part of your benefit. So remember, we'll go to the next slide. I think it might be part of the next slide. So we talk about this. So this is kind of some of the tragedy in our country, right? So in the United States, we spend the most, this is old data, like relatively old, per capita health expenditures. And this, I'm not going to go into politics, but we spend a huge amount of money, spending money on healthcare, right? Look how the drastic difference is between us and the next one below us, right? So we're spending a huge amount of money on healthcare. But if you go to the next slide, the years don't match, but we rank the lowest in terms of overall performance in our healthcare. So we're spending, and actually, if you look, this is from 2014. It wasn't a good slide, so I didn't use it. This is meant for just emphasis. But if you look at some of the same surveys, we're not even on the list anymore. We're not even in like ranking. So we're spending all this money. A lot of people who are still really sick and are still going to pass away, and we're not even getting good healthcare. We're just spending money. And so we're looking toward trying to figure out utilizing something like palliative care and hospice to identify the people that still want to spend the money on their care. They may want to utilize a different kind of benefit that is still covered under their insurance, but maybe do it in a better way. Okay, so next slide. Okay, so what does hospice provide if you're choosing this? Remember, when we got to hospice is because medically it's appropriate. Remember that surprise question? If I would not be surprised that I would pass away from this illness in about 6 months, that's something to think about. But it also has to match with your goals of care and having all the discussions about whether this is the right thing for me. But if you choose that it's the right thing for you, what benefit do you get under hospice? So you get a nurse that's going to come to your house. You have 24/7 access to that RN. There's always someone on call, and an MD is always on call. So I take call with my colleagues for VNA, and I'm on call for a week at a time for all the nights and all the weekends for all the state of VNA. So there's always a doctor like myself that the nurses have to call if they have some questions about their care. In aid, I have to fix that. That's a typo. Remind me to do that. Aid, like a custodial aid, is AIDE. I apologize. Okay, so an aid for custodial care, it's an average only about 1.5 hours. I wouldn't even say 7 days a week. I would probably say at this point it's 3 to 5 days a week, based on some of the home health aid shortages and the cost of it. So you're not getting, even if it's 7 days a week, it's only an hour and a half a day that's provided under Medicare. So the rest of the 22 hours of the day is going to be an issue in how to take care of somebody. There's coverage for all medications and equipments that are needed to take care of the patient for symptom management. There may be some medications that are really not intended they're there for cure and not for support. And so you still can get the medication through your prescription plan under Medicare, but it wouldn't be paid for under hospice or sent to you by hospice. But the medications are generally delivered to your house. You don't have to go to a local pharmacy generally. And they're there. There's always a box of medication that's in your house. So in an emergency, if you need a medication for the most common symptoms, there's already something sitting in your refrigerator to be able to administer. And it has an interdisciplinary support, emotional and social support of a social worker and a chaplain. And they do bereavement for 13 months. They'll follow up with you if you desire. There's 13 months after the person passed away. They'll support the family unit in terms of that bereavement. Okay, next slide. Okay, so who pays for hospice, right? We talked about that, how different parts of Medicare. So it comes out of Medicare Part A. When you sign consent, because it's an insurance designation, you have to sign consent for hospice. You are switching your Part A to hospice. And now that makes sense, right? Because based on your goals of care, presumably you're not going to the hospital Probably not anymore, but we can talk about that in a minute, but certainly not as much as you were. And so that Medicare Part A switches over to the hospice benefit. The difference is that, remember we said that there was that 20% copay, that Medicare pays 80%. Medicare pays 100% of everything that is covered under Medicare. There is no copay. So some people who are sure that they're on hospice, sometimes they cancel and don't pay the premiums for their secondary insurance. You know, you have to be really sure that you're not going to need it again, but something to keep in mind if you're talking about cost savings. Now, the custodial care, remember we said it's only 22 hours that you have 22 hours that you need to kind of fill in, right, in custodial care. So the only payer source that will pay for that time is Medicaid. And we're going to talk a little bit more in detail of what that means. So Medicaid is a financially based state program to pay for support. If some people have a long-term care policy that they started out, long-term care policies are generally very different depending on all the fine print. But the general concept of long-term care is you pay a premium and it will help pay for care. But almost all long-term care policies that I have heard about, you have about a 3-month period where you have to pay out of pocket before it'll kick in. So you have to prepare financially to be able to pay for those 3 months as well, not only the premium for the program, for the policy. And then your money, it's all cash, right, to pay for care. So give you a sense of it. So having an aide in your house, it depends if you're having a 24-hour aide or you're paying hourly. It's about $25 an hour to pay for an aide. Some agencies will have a minimum number of hours that you have to hire someone for. If you're going to live at a long-term care facility, average in the state of New Jersey is about $400 a day. So it's like staying in a 5-star hotel every single day of your life for the remainder of your days. It's a lot of money. And so you really have to plan for that. And it's funny, I always say to the residents who I'm teaching, you know, they don't teach you about financial planning, but you got to start now because you have to put that money away. Every little bit counts toward the end because the care there may not even be Medicare when I'm eligible. Who knows? Certainly the care keeps getting more expensive. And so you really have to be able to take care of your loved ones if you're not going to be eligible for Medicaid financially. Okay, next slide.
Oops, sorry, I went one.
Okay, no problem. Okay, so I tried to put some humor in it because I don't have videos, but this is the quandary with Medicaid, right? Is that most of us, some people will, but many in a middle class environment will never, they don't have all the gobs of money to pay whatever they need for care, but they're over the limit of Medicaid, and we're going to talk about that. And that pocket is where many of us live. And you have to really prepare for that, because if you don't prepare for it, that's the stressors that I hear all the time, right? I see patients in the hospital who have been very ill and they finally decide that their wishes are that they want to go home on hospice and they really want to go home, but their children all work. They have some money, but not a lot of money. And what are they going to do? Because who's going to take care of them? And it's unsafe for them to be home by themselves, right? They need someone, even with hospice, you still need someone in the house if they need symptom management or they need to call for help or they need to clean themselves because they can't do it themselves. There's all these stressors that come about. But that little tiny t-shirt is kind of where you have to squeeze yourself in to even consider something like Medicaid. And so that's why it's a big stressor, like I started out this talk tonight. Okay, so how could you be eligible for Medicaid? Because I'll tell you, I trained in New York, and in New York City, Medicaid was your golden ticket because it's a state-based benefit. And in New York State, in the city of New York, because they don't have a lot of nursing homes, because it doesn't exist because of the geography of the city, is that you could get 24-hour aides in your house completely covered by Medicaid. That doesn't exist in New Jersey. Okay. In New Jersey, the most amount of hours you can get, the max is 8 hours a day. So there still remains some time where you're going to have to figure that out. It does certainly helps. And I forgot, I should have put that in. If anyone is a VA, another source for support is if you're a VA patient and you have if you have service-connected benefits, you might get some help for home health aides or long-term care through VA. So just, I'm sorry, I didn't put that in as I'm thinking. Okay, so you have to be a New Jersey resident over the age of 65 or permanently disabled. And there's income requirements, whether you're single, whether you're married, whether you join together, you file jointly your taxes or not. And the big thing is that there's a 5-year look back. You need to provide Medicaid with 5 years of financial records, quarterly records. And there's a whole, if you're going to apply, I'm not here to tell you exactly how to apply. Nothing I say is absolute. You really should be looking towards some financial advisor or a lawyer to help you do this. If you can, Board of Social Services can give you some guidance at this too. But you need to provide records for a very long time. 5 years is a long time. So if you didn't plan for it, that's a lot of stressors also, right? So sometimes I hear, and this is really important for planning, is, kids come in and they say, oh yeah, I'm their child, but I don't have access to their money. So now they're really sick. They don't have the ability to take care of themselves. They don't have the ability to go to the bank. Their memory loss has gotten worse, and now they can't really designate anybody. And now we're, out in the ocean without a paddle because I don't have a financial power of attorney. I can't access their records. You can't even apply for Medicaid if you don't have a financial proxy, if you don't have access to their bank records. So it's really important to plan, is that if someone has an illness that you think that you're not ready for hospice, but you still think that some point in the future, they're going to have an issue with their memory, taking care of themselves, where you're going to have to access finances, you need to do. It's like the best thing you could do for yourself and your loved ones is to complete a financial power of attorney, a durable power of attorney that honestly needs to be done with best with a lawyer, but you can print one out on the internet and you just need a notary. You either need a notary or you need a lawyer. You can it's medical proxies you can just do with witnesses, but not for financial stuff. You need to do that before the person can't designate anymore, because then it's really a difficulty. Mm-hmm. Okay, next slide. Okay, this is crazy, but this is how it feels, okay? When they talk about income, this is what they're talking about. And again, this is not specific advice for anyone individually, but you get a sense of this, right? Is that you may have some of this stuff. So how do I really know? So you really have to start planning ahead of time. Okay, next slide. So this is a little bit also a busy slide, but I want to just give you the sense of it. If you're going to need to apply for Medicaid, you need to think about this. But it's, like I said, it's based on if you're single or you're married, if you're applying for Medicaid for both you and your spouse or only one spouse, right? If we'll just give an example. So a single person, you can have, oh, sorry, I didn't clarify this. Medicaid could help you. You have to apply. It's the same application, but you choose which one you want. Do you want Medicaid to stay in the community, or do you want Medicaid to live in a nursing home? Okay, you split off once you start the application. But let's say we'll look at the first line, and you see someone who's single, who wants to live in a nursing home, has an income limit of $22,742 per month, and they have an asset limit, like all those things we just said, you may have at $2,000. Now, let's say look someone married, and let's say you're applying for as a spouse, right? So one person is sicker than the other, and one person needs to live in a nursing home, and the other one's going to stay home. If you look all the way on the right side, it's the income limit, the same income limit per month for the applicant, for the person that you're applying, but look at all the asset limits, right? So the person themselves who are applying can only have $2,000 in their name, but the other person can have money because you're allowed to have money to live because they're not the one who's applying, but the max they can have is $148,620 from the non-applicant. So if you have all the pensions and you have investments and you have property and all this stuff, you're never going to be eligible for Medicaid. But there is a catch, but a legal catch. Okay. So you have to really plan for this because so it's really wonderful if you don't have any financial ability to pay for your care and you're already eligible for Medicaid, right? You just have to do the annoyance of doing the application. But again, remember, for all of us in that middle of the road kind of place, this is extremely hard to do. because you have to really think about it and plan for it. Okay, so if you go to the next slide. Okay, so what is the, let's say I make too much money, right? Or I have too much money. So again, this is a caveat, you need to do this legally, and you need to find a lawyer that will help you or a financial planner that will help you. But there is a way to hide your money legally. But you can't do it 6 months before you need to do it. Remember, there's a 5-year look back. So if you have all this investment and then you create what's called a qualified income trust, where you essentially put all your value and give it over to someone else, your kids, your neighbor, whoever you're doing, right? And then you basically have to ask them to pay for things, right? Nothing's in your name anymore. You're allowed to keep some money. I mean, that's again, you have to go through all the details with a really qualified person. But the general concept is that you change over your assets to someone else who then has a hold of your money. It's under their names or their names, whoever you do it. But your assets are no longer under your name. And so when you go to apply, they won't say, and remember, it's 5 years. So you can't have $1 million and then put it in a trust and then 6 months later say, oh, I don't have any money. I want to live in a nursing home. Can you pay for it? Right? So there are ways to do this legally, but you really do need to talk to the right people to get the right advice. People talk all the time. I own my own house. I get this question all the time. Okay. It depends on who is going to live in the house, right? So if you have that married couple scenario, right, and one person is not going to be able to live in the house, but the other one needs to live in the house, they're not going to make you homeless because someone needs to apply for Medicaid. But just a caveat is that Medicaid can, I don't know if it's on the next slide. Could you just go for a second, Mary Beth?
Go ahead. Yeah.
Just for, oh no, I'll go back. Okay. So, so there is this concept is that Medicaid can come back to you later on. And when they go to they can apply to the state, the estate of your estate. And if you go to sell that house and it's under your name, they can ask you for that money back. So if there's value in the house, it may deplete its value if you've applied for Medicaid, and they may ask for some of that money back. But if you want to save it for your kids, again, you have to do it legally and in the right way and in the right time frame. But you may need to turn over that house to somebody else. Okay, so just keep that in mind. So I have too much money in my savings. You're allowed to use some of these. They won't ding you for some of these costs, right? If you're spending some of that money down, not just to give it away to your grandchildren, but if you're using it to buy things to take care of yourself, they're not going to say, oh, that was a very large payment. Now you don't get Medicaid, right? If you pre-planned for your funeral, that could be thousands of dollars. And that depletes your value closer enough to be Medicaid, they're not going to say, oh, no, you can't pay for that. They are a little bit sensible in that way. Okay, next slide. Stressed yet? This is why this stuff is so stressful, is because there's so much to think about. Okay, so now I loved this. I love this cartoon. I know it's so crazy. It's like black humor, like dark humor, is that it says it's Medicaid cutoff for the LD company with income over $390. Okay, so the only income as a couple, and it says we're old, sick, poor, and in love. Does that cover all the necessary grounds for a divorce? Okay, so if you have this joint issue and you're married, obviously that's not where we want you to go. You just really need to think about and plan. Okay. Okay, so where can you live if you're on hospice? You can live anywhere. Home hospice is your home. It could be in your house. You can be in something like an assisted living environment and a long-term care facility. We're going to talk about some pros and cons for each. Okay, so the benefits of living at home is your home, right? It may be a personal goal for someone to be there. Family can be in and out as they choose without visitation. I know for COVID, this was more of an issue because you couldn't go into facility to see people. They were a little bit more lenient if someone was on hospice, but just someone living there, they would restrict you. You couldn't go there. You had to get tested. Thank God we're in a better place now, but that could always happen again, right? So they are in charge, so they can restrict visitation. The challenge is that your family needs to be present 24/7, right? To help take care of you and do other things. For some people, the home environment may just not work, whether that's because there are young children in the home, if the patient is young, There are multiple generations in the home, someone who has a spouse that has dementia, that having someone pass away in the house may not be a great idea, right? There's a lot of factors that come into play. They can't provide the care for 24/7. They'd be alone too much of the time, where home may not work. Okay, next. So a long-term care environment, the benefits of it is that you, instead of maybe hiring some help at home, you still have that financial ability, but you're in a place and there's always custodial care. I mean, I remember when my kids were young and we were in the season of hiring babysitters, right? And the babysitter wouldn't show up, right? It was like my whole life would turn upside down when the babysitter didn't show up or they quit or whatever the story was. The same thing is true kind of at home. If you're hiring help, if you're doing it under the table with hiring someone, that's a whole different story. But if you're doing it through an agency, generally they'll send someone new, but there may be a delay and then it's a new person and it's all this other jazz. So similar, people don't show up, right? People don't show up to their jobs just like anything else. But in an environment of long-term care, there's always going to be someone there, whether they're understaffed or not. That's a whole nother discussion for another time. But there is usually someone always there to help. Again, it's a benefit if home is not feasible. I said, we talked about visiting policies. There's a risk of what's called nosocomial infections. Those are infections kind of being in an environment of a nursing home. A lot of the COVID spread a lot during that time for people in nursing homes. You have one person who has COVID and then the whole floor has COVID. There's other kind of things to be worried about. And there is a larger financial burden of paying for the long-term care like we talked about. Oh, I thought I had a slide for assisted living. Let me just explain assisted living and then
I didn't skip it, did I?
I thought I put it in. It's not there.
Okay.
Okay, so just to remember, what's assisted living? Assisted living is an environment where there's variable levels in most of the buildings where you go from a variation of living in your own kind of apartment with a small kitchen area that you can make your own food. You can eat at there's usually a dining room where you eat meals socially with other people. There's activities in the building. There are some that transition patients to not even having any kitchen at all, right? Or just something like a microwave if they're not necessarily able or cognitively able to prepare food. All variable depending on the facility that you're looking at, but you pay in to be there. Okay, so it's actually more expensive than something like a long-term care nursing home environment. Generally, people who just need additional limited support, right? They usually have a nursing office. Some places have nursing all the time. Some places don't. You have to really ask those questions. They generally have aides. I don't want to sound cynical because they are a very good value for a lot of people, but I find that a lot of assisted livings nickel and dime people. Right. So they say, okay, this is a flat fee to get in, but we deem that you need an additional private aid. And now you have to pay X number of dollars because of the amount of care that you need. Right. So at some point, it becomes too financially burdensome. And that's why you kind of transition to someone who needs to be in a long-term care environment. But in theory, you could have your own private aid in assisted living in your own apartment. Right. So you could hire, but it's an additional cost. Right. So those kind of things about assisted living. It has a little bit, generally, a more social environment than something like a long-term care facility, although they do have activities. But the clientele, when you're going to a long-term care environment, generally is someone who is more advanced in their illness, who really needs complete care, as opposed to an assisted living environment where they just need assistance to live. Okay, so this is my last slide. And what I wanted to answer is, remember that chaos of the hospital when we started? So although this looks like a busy slide, it's much more organized, right? If you're thinking about your thoughts about how you're going to do this, putting the pieces of the people together that you need to help to make these decisions will make it feel less chaotic, more like a picture or an artwork, right? Where you have someone in the middle that's the focus, and you're using all of these resources to create a plan that's not as stressful and chaotic than we started out with. So I appreciate your attention, and I'm open to some questions if you have any.
Take this down. I'll start off the question. Dr. Goldberg, if you are declared to be on hospice and you wind up extending your life beyond the 6 months, then what happens?
Okay, great question. I guess I didn't address that. So thank you for asking. So the definition we said about 6 months, it's a guess, right? So just because you live for 6 months doesn't mean automatically get dropped off of hospice. So the way it works is that at regular intervals, your situation is assessed to see if you are still eligible for hospice. So it's generally the first 90 days and then every 60 days after that. And when the medical team is going to decide whether you still remain eligible to be on hospice. It doesn't mean that you have to pass away, is that you have to show a decline. Okay, so they have to say at month number 6 or 6, you are worse than you were on day 1 when you came on hospice. And if that is true, then you could stay on hospice for a long time. There are people on hospice for 1.5 years, right?
Okay.
It's not that it's only a 6-month benefit. As long as you are eligible to meet their criteria to be on hospice, you can stay on hospice for much longer.
Okay, thank you. Yeah. I had chat was a thank you, but do you have any other questions? Feel free to, Francis has a question.
My question is, if you're Medicaid eligible, aren't the facilities limited in how many beds they have for Medicaid patients?
Yes, so you don't have as many choices and you need
Right.
to have a facility that has a Medicaid, but they are required federally to have Medicaid beds. Okay, so a facility can't say, oh, we don't take Medicaid,
Yeah.
right? A long-term care, because they'll get in trouble. So they may have limited Medicaid beds, and they may not be in the top
Right.
facilities,
That's what
right,
I
where
thought.
you may want to be,
Okay.
but it is completely paid for. So that's a trade-off, right?
Yeah. Okay, that's what I thought, and okay, that answers my question. Thank you.
Yeah.
Okay.
Something else that I don't know if I'll wait another minute if there are questions, but something else I didn't talk about, which I think is important also for some of the misconceptions about hospice itself. So Mary Beth asked a really good question about what happens if you didn't pass away at 6 months. The other thing is that generally we talk about, are you never allowed to go to the hospital if you're on hospice, right? People ask that all the time. So the answer is it depends. Okay, it depends on why you're going to the hospital. So if let's say, you have congestive heart failure and you've chosen the pathway of hospice and you're at home and you're starting having shortness of breath and you decide, I don't want to just take the medications and stay home. I want to go to the hospital and get IV Lasix and all this jazz and see what's going on with me. And so if you're choosing to go to the hospital for active aggressive treatment for the reason why you're on hospice, you're going to have to come off hospice to stay at the hospital, right? You could stay, but remember what happens is, remember we said Medicare, it's Part A that goes to hospice. So you have to sign what's called a revocation letter, where you sign, you go off the hospice program and your Medicare Part A reverts back to the hospital. Okay, so you have the hospital coverage. It's just that you have to sign that revocation paperwork so that you're no longer on hospice. That's if you go to the hospital because of the reason, the diagnosis as to why you're on hospice. But let's say that same patient has congestive heart failure and then falls and breaks their hip. And they want to go to the hospital to get surgery to get their hip fixed, right? You don't technically have to come off hospice because you're going for something that's unrelated to your diagnosis. So your Medicare will cover the hip fracture and the surgery and all that jazz without technically needing to sign that revocation form. Now, if your care is complicated by heart issues, that may make it a little mucky, and your agency for hospice might tell you to sign the revocation, but there really isn't any ding for the patient if they come on and off hospice. It's a ding for the agency that you choose because Medicare wants them to keep you on hospice, right? So if you're on and off hospice a lot, it becomes an issue for the hospice agency more than it is a problem for you. There's no rule like I can't come off hospice, like, the whole subacute rehab days. There's no such thing as like you can only be on hospice X number of days of the year, or if you're eligible, right? If you come on off hospice, you're not going to get it again. Like there's no such thing for the patient. It does become an issue for the agency that you are on hospice with. Is that clear?
Yes.
So it depends on why you're coming to the hospital. You can see this comes up a lot. Oh, I can't go to my doctors anymore. I'm not going to come on hospice. You can go to any doctor. Remember, it's Part B, right? Part A is your hospice. Part B is when you go to the doctor, they bill it under a different part of Medicare. So you're allowed to go to any specialist. However, your specialist has to bill a different way knowing you're on hospice. Okay, so it's a back office thing. So they just need to know that you're on hospice because they have to use different codes. But they should, if you are on hospice and you want to go to your specialist and they're telling you, oh, you can't come to see us because you're on hospice, tell your hospice agency nurse because they will help you navigate that. You should never pay out of pocket to go to a specialist because they just need to be educated about how to bill for it and still get paid.
See, this is great information that we need to know this stuff.
And it's just because they don't want the hassle of it, but you should never pay out of pocket to see a doctor under a hospice. It depends on why you're going. That's why it's complicated. It's like why you're going to the doctor. Are you going? Is it related to your hospice diagnosis? Is it not? So that's why don't even get involved. Just tell your hospice nurse if you're on hospice that this is what you heard and they'll help facilitate for you.
Okay. Yeah. Do we have any other questions? I'm looking sideways because I have my second computer here. Francis, go ahead.
I have a question. In palliative care, I might have missed it last week. You can still, in palliative care, you still can get treatment, right?
Yes. So palliative care, they're talking about palliative care is just like any other specialist, right? The whole point of palliative care is that it's concurrent with any treatment you want.
Right.
If you want help with symptoms or identifying your goals of care or making sure you have all the paperwork right, and you have access to a palliative care provider, it could be done at any point with any treatment. You don't have to stop anything to be on a palliative care program.
Okay. Good.
And to that point too, we will make sure that both last week and this week's sessions are edited so that everyone can review everything before session 3. So everyone has all the background information, because I have a feeling we're going to have a lot of people joining us for session 3 that may not have come to 1 and 2. So we'll make sure everyone's on the same page.
Yeah. And I'm so excited for session 3, not because it's me, but because I'm bringing with me 2 wonderful people from our hospice program, one of our chaplains and one of our social workers. And they're wonderful. And I think you're going to love the interaction with them. They're going to be doing more of the speaking than I will next time, but I'll be on to kind of start off the conversation and be here to answer questions. But they're the resource that we go to. We're going to be talking next time is how to share with your family and friends and some benefits, how you explain that to them. If you're on the mindset that you want hospice and they may not agree, or they do agree and you don't agree, but kind of that interaction with your caregiving team. So if you could spread the word to your family, it's probably a really good session for your support system to be there too, to kind of hear what advice they have for the next time.